Okay, this is going to be a really quick voiceover because most of this is demo that I will be doing in class. So please come to class to see demo of most of these topics. We're going to go over troubleshooting of urethral catheters and continuous bladder irrigation in class. I am going to point out some hints on suprapubics, nephrostomy tubes, and continent and incontinent urostomy in this voiceover. But as terms of urethral catheters and continuous bladder irrigation, most of that is classroom demo. So again, if you are not going to be able to make it to class and you do want to see a troubleshooting demo, or if you want to see both, I appreciate both. The troubleshooting demo is a 16-minute video that does cover CAUTI prevention, manual irrigation, repositioning the Foley catheter, and continuous bladder irrigation and catheters under traction. That is the content of that 16-minute video. It's a very good video, but it's not nearly as good as my demo. So you need to come to class to see my demos. A couple of things to point out on catheters. You can read through on this. Hopefully you know all this information anyway. But in the hospital, so there's people have asked me numerous years in the hospital, why does it have to be a sterile procedure, and at home patients can catheterize themselves using just soap and water in a clean procedure? Well, at home they're only taking care of themselves. In a hospital, we're minimizing cross-contamination between patients, and the more sterile your procedure, the less risk of cross-contamination. We're also always trying to get rid of catheters as soon as possible. Remember, a catheter is a straight main highway into your bladder, which is a main highway for bacteria, very high risk of infection. Make sure your catheters are secured. If you do not have a catheter secured over to the leg, to the side, taped down, securely wrapped with any kind of commercial device, basically any pressure or traction on that catheter is going to be pulling directly on your bladder and urethral sphincter and can damage that sphincter over time. So please secure all your catheters just to prevent any trouble later on down the line with your catheter. And drainage bags should always be below the patient. Do not hang them on the end of the bed. Please don't hang them on the end of the bed. That is at the same level of the bladder and things do not drain. Urinary retention leads to kidney infections and kidney damage. So please do not retain urine, especially if you already have a catheter in. At home, patients should use a clean, it's non-sterile, but as clean as possible procedure before doing any kind of intermittent catheterization. And always, whenever you're looking at frequency for catheterizations, we are trying to prevent bladder retention. And at the hospital, we have access to a bladder scan, or it will be ordered every 4 to 6 hours. We will catheterize as needed, or every 4 to 6 hours. And at home, it should be scheduled every 4 to 6 hours and just before bedtime. We are trying to prevent bladder retention and urine sitting in the bladder for longer than is necessary, because a full bladder full of bacteria can reflux into the kidney, causing an infection. So please empty those catheters, whether it's straight cathing, emptying a bag, or anything. Please empty them out every 4 to 6 hours. Just manual irrigation. Again, I will do this demo in class on how to irrigate. Why would we need to irrigate a catheter? They can get clogged up, and remember, clogged up catheters don't drain. Urinary retention causes a risk of renal infection and renal damage. So please drain out the catheters. If the catheter is not draining, and you bladder scan. Whenever a catheter is not draining, your next step should be to bladder scan, if you can. If there is fluid in the bladder and the catheter is not draining, something is blocking the outflow, and you can irrigate the catheter. No order required. There are so many people that do not irrigate catheters because they think they need an order from a physician. You do not need an order from a physician to irrigate a catheter. That is keeping your catheter patent, and that is like asking for an order to cough and deep breathe. That is keeping your airway patent. Please clean out catheters if you need to. You're just going to do it sterilely, and I will demo it in class. Watch the video or read through the directions if you want to go forward before the class. Repositioning a catheter is also another troubleshooting technique, which I will demo in class. The problem is that balloon sitting in the bladder there on this picture here. This is the balloon sitting in the bladder. You can see it is sitting at the base of the bladder, and it is right on top of the prostate, the urethral sphincter. Well, in Arizona and in dry climates, this balloon can deflate a bit. And when that balloon deflates a bit, it can migrate down into the urethra, and especially in men, cause quite a bit of pain if that balloon is sitting in the right at the urethral sphincter or in the urethra around the prostate. It's going to cause pain and spasming and hurting. Foley should not hurt a patient ever. They can feel a feeling of pressure because that balloon sitting at the base of the bladder might stimulate the bladder to feel like it's full, but they should not have pain. If your patient is complaining of pain or is leaking around the catheter, that catheter might have migrated in the urethra and is causing spasms of the urethra. So what we're going to do is really just clean the catheter off with betadine that's south of the entrance site and push that catheter, deflate the balloon, push it back into the bladder, and then reinflate the balloon, basically. We can do that, no order required. I will tell you a great story of a patient that came out to us post cardiac surgery, and the doctor came out and said, we're going to need a renal consult right away. He hasn't peed for the entire surgery. He's probably in renal failure. This is going to complicate his extubation, and it's going to be a big problem afterwards. I'm really bummed. He didn't have any signs or symptoms of renal failure. I don't know why this happened. So we get him all settled in after he comes out of the surgery suite, and I do a quick catheter reposition because when I did a bladder scan, that bladder had 1,500 in it. The patient was anesthetized. He had a catheter. And because he wasn't draining into the urine bag, the surgeon and the anesthesiologist assumed that the patient had renal failure. They didn't have a bladder scan. I did the bladder scan, found 1,500 in the bladder. So did a quick reposition. I don't know if maybe the tip of the catheter had gotten bent underneath the balloon. I'm not sure what happened, but a quick reposition, that bladder drained 1,500, and that is to date, after 20 some years in cardiac surgery, the only time a cardiac surgeon has ever hugged me was when I told him I repositioned the catheter and got 1,500 out of the bladder. And when he realized his patient wasn't in renal failure, he just was so excited that such a simple thing like repositioning the catheter could make such a difference. It's a tube. Tubes get kinked. Repositioning them is something that you can do. I will demo it in class. Continuous bladder irrigation is much easier demoed than explained. It really is just something where, you can disconnect the catheter and flush it with 60 cc's. That's a manual irrigation. This is something where we know they're going to have lots of debris in their bladder, and we want to continuously just run saline through the bladder and irrigate that bladder and keep that catheter clear. I will explain it and do a demo with a water bottle and a catheter in class. So let's just save that for class time. Let's talk a little bit about suprapubic catheters. You may or may not have seen these. These are catheters that are entered in the bladder through the abdomen. This is surgically inserted. We don't insert these ourselves. Surgically inserted through the abdomen into the bladder, and this is used when there is no outlet through the urethra. Maybe they've had urethral damage, maybe they've had surgery on it, maybe they've had trauma. The normal urinary tract is compromised, but we still need to empty a bladder. They will get a suprapubic catheter. It's above the pubic bone, which is why it's called suprapubic, and it drains out to a catheter bag, just like a regular urine catheter. It's prone to poor drainage. Look at that patient. Look at that picture where he's laying down on his back. Do you think that anything is going to drain upwards like that? Absolutely not. Putting a drainage bag down below the patient is helpful, but this patient may need to turn side to side, sit upright, and get that tubing, kind of have a little bit of suction on that tubing by milking it up and down, by raising and lowering it to get the bladder drained all the time. Assess the bladder frequently with a bladder scanner or with palpation to see if it is full or empty. Make sure that you are turning your patients frequently and getting them to drain if they have a suprapubic catheter. That's really all I want to point out with suprapubics, is that they are prone to very poor drainage because of the way that they're inserted. Really keeping your patient on the side keeps it draining a lot better. Nephrostomy tubes. You may see these after kidney procedures. This is actually a catheter that is directly entered through the kidney into the renal pelvis. This is only used really when the ureters or bladder is dysfunctional, but you have to keep the kidney draining. Remember, the renal pelvis only holds about 5 to 7 milliliters of urine. So let's say for some reason we had to do surgery on this. Maybe you have cancer, maybe you have a obstruction, maybe you have a blockage. Maybe they're waiting for a big stone to pass. This kidney still needs to drain, but for some reason the ureter is not functional, or the bladder is not functional, and there's no way for it to drain into a storage area. They can get a nephrostomy tube, which is a tube, like I said, placed directly into the renal pelvis, but that renal pelvis cannot distend and can only hold about 5 milliliters, maybe 7 max, of drainage. So it needs to be, the big thing about this is that it needs to be continuously draining. There shouldn't be, you don't check this every 4 hours, because by the time 4 hours have gone by, if you found out it's not draining and that kidney's putting out 30 to 40 milliliters an hour, it will back up immediately and cause kidney damage. Ensure continuous drainage. You need to check on these tubes about every hour and make sure that they are draining. High risk of infection. They are directly inserted into the kidney. The kidney is a very vascular organ with lots of blood vessels, and bacteria that get straight into that kidney now have a direct route to infecting the kidney and infecting your bloodstream. High risk of infection with a nephrostomy tube, and they must be draining at all times. The kidney has no room for distension. Any more will back up and damage the kidney. So you may have to irrigate these boys or get them draining a little bit more commonly than a Foley catheter. You can irrigate them very gently with 5 milliliters of sterile saline to keep them clean and keep them from getting clogged. But again, just remember, make sure that they are constantly draining. Watch them more often. This is not a put it in and leave it and check on it every shift. This is something that you need to be checking every few hours. Make sure it is continuously draining, irrigating with needed. But because the renal pelvis only holds 5 to 7 milliliters, do not inject more than 5 milliliters into that kidney to irrigate it. And I think that is the tubes. We're going to talk for just a little bit about urostomies, which is where we're diverting urine to our surface somewhere. Urostomies are either continent or incontinent. So let's talk a little bit about what that means. Incontinent means you got a stoma and it leaks constantly. Incontinent means that output is constantly draining, and as the kidney makes it, it dribbles out. It will be constantly dribbling. You are unable to control it. It will constantly just be a drain. It requires an ostomy bag on the surface of the skin or some kind of appliance to collect the urine as it dribbles out. Most of these use intestine. This is because the bladder is removed, the ureters had surgery, something is wrong. Usually this happens quite a bit after bladder cancer. But the ureters need to be diverted somewhere. The kidney can't hold anything. Your storage facility is gone or damaged or compromised or broken. And so they take a little piece of intestine, hook up the ureters to it, and divert that out to the surface of the skin. You do have a stoma. Whenever intestine is diverted out to the skin, you have a stoma. And it just basically is the drain. As the kidney makes urine, it drains out. So you're constantly draining urine. You should keep an eye on the bag, change the bag when it is half to 3/4 full. Again, retained urine just harbors bacteria. Bacteria can eat anything in the urine. They love it. It's full of waste products, but waste products to us are food to bacteria. So really a full bag of urine creates a lot of bacteria, And if that bacteria get up against the stoma, they can then crawl into the conduit and into the ureters and into the kidney. So keep those bags drained. Drain them when they're about half full. Don't wait for them to be popping, bursting open. But drain those bags out, clean those, get those bags drained so that the retained urine doesn't get bacteria in it into the stoma. Look at the stoma site, always with stoma care. I know you went over this in block 1, but just to refresh, stomas should always be pink or red. They should not be dusky or dark or purple. A little bit of mucus drainage is normal. This is a piece of intestine that is being used. So that piece of intestine does create mucus. Intestine creates mucus to protect itself. So a little bit of mucus drainage is normal. We're not going to be freaking out about it. But anything cloudy or foul smelling, we will report. That's a sign of infection. And remember, now we've lost our bladder, our urethra, the innervated sections. So the dysuria, the pain, that goes away. Our sign of infection is really cloudy, foul-smelling urine. That's our first sign of infection, and that can rapidly increase to a kidney infection. Once you have a fever with a urostomy, it's probably in the kidney. Flank pain, nausea, signs of pyelonephritis. So just keep an eye on your ostomy, empty that bag out, and that's pretty much it with an incontinent urostomy. It always has to have a bag on it because it's always dribbling. The continent urostomy creates a fake little bladder. It's not a real bladder. It's the same. Their bladder has disappeared. It's either been damaged or you had cancer or something happened. So instead of diverting it straight to the surface, they kind of blow up. They use a balloon to blow up and make a big piece of intestine there. So this is still intestine that they kind of, blow up and distend to create a false bladder. They have pouches, but the pouches are not on the outside. They're on the inside. They're intestinal pouches. And it creates a little false bladder. And you can see how they kind of fold it in on itself. And it creates little fake catheter. That's not the word I'm looking for. Fake sphincters, I guess. They're little valves, basically, that with enough pressure, if this little fake intestine balloon gets full, it will dribble out. But it's supposed to hold probably about 200, 300 milliliters worth of urine. So as the kidney makes it, you can see up at the top here, these are your ureters attached to the intestine here. And as your kidney makes it, it dribbles into this little fake bladder. And it just gets stored there. Now, of course, if it gets really, really full and really, really distended, it will leak out. But what you're going to need to do is you need to empty this little faked bladder. The only way it leaks out is if it gets over distended. So you need to leak, and because it's folded in on itself, it creates kind of a closed surface there. So the only way to get fluid out of there is to catheterize it. So the patient will self-catheterize it. They do have a stoma. The stoma is a little bit smaller and not quite as prominent as a usual intestinal stoma. But they will have to go in there with a catheter and drain out that fake little bladder that we made out of intestine. Because it's made out of intestine, a little mucus drainage from it is normal, but really because of the way it's folded in on itself, they should not dribble urine out of it unless their fake bladder is distended. So this will be managed by the patient and needs to be catheterized to empty. Now, this has to be done with a competent patient, so not the demented patient, not the patient that needs someone to take care of them, because if this gets distended, not only will it start to leak, but remember, retained urine that in a distended area like this can leak back into the ureters and into the kidney. So anything sitting in here can grow bacteria and can leak back if it's not emptied frequently. So if your patient is unable to self-catheterize themselves or can't take care of themselves, this probably isn't the catheter of choice. It'll be easier to do a incontinent urostomy and have a bag. Because these bladders are not as big as regular bladders and don't have as much room to distend. Like I said, they only hold about 200, 300 milliliters of urine, and they need to be catheterized a little bit more often. So definitely they need to catheterize themselves at least every 4 to 6 hours, possibly more. But remember, every time you catheterize this bladder, you are introducing a risk of infection in there. So that needs to be done cleanly. When needed. They probably don't want to be catheterizing it every half hour, every hour. That's too much of a risk of infection. Every 4 to 6 hours, if a patient's making 70 milliliters an hour of urine and every 4 hours is about 300 milliliters, that should be perfectly fine. Looking again for signs of infection. This is not innervated. There won't be urgency or frequency. Cloudy, foul-smelling urine is the first sign of an infection there. And these also have a little bit of changes in lab values. This is a piece of intestine that creates this fake bladder. And intestine is lovely and it's useful, but intestine's job, so bladder has like a coating around it that keeps you from reabsorbing the waste into your bloodstream. Whereas the intestine, it's built to allow things to absorb from it into the bloodstream. So when you make a bladder pouch out of intestine, the blood vessels nourishing it sometimes do end up reabsorbing some of the waste. So there is a little bit of a chance of higher BUN creatinine levels. It won't be crazy high, but they'll be just chronically on the high end of normal. Potential for electrolyte imbalances. Again, the intestine is built to have things absorbed from it. And so the blood vessels nourishing this pouch will absorb some of the waste out of the bladder, out of the fake bladder. So just so you know, that is something with the continent. But the main key with a continent is it needs to be self-catheterized, and it needs to be self-catheterized pretty frequently, every 4 to 6 hours, to keep it emptied. It has no room for distension, and retained distended intestinal bladder will damage the pouch if it happens too often, and can cause problems for that long-term pouch. So that is the difference between continent and incontinent. Incontinent means you're dribbling out constantly into a bag or a pouch outside the skin, and continent means that the pouch is internally and that it needs to be self-catheterized. So that is the end of that. I will see you in class for demo, and have a great weekend.